Next, I would call upon the chairpersons for the next presentation, Dr. Arun Chinchole sir, Dr. Raj Rajeshwar Diori sir, and Dr. Neeta Kadam ma'am for the next presentation. By Dr. Sharad Kondekar sir on imaging in renal masses.
Good afternoon all. I'll be talking on cross-sectional imaging in renal masses. At the outset, I would like to thank the organizers for inviting me here. And another thing is, I will not be talking on much of a theory. I will not go into the details of the theory because that anybody can read. I'll show you a few images, and more than that, what I would like to share with you is what should be your approach in cases of renal masses. So that is more important, because if you find a lesion in the kidney, first question is what should be your approach towards that lesion. So that we'll discuss in detail. These are the modalities which we can use for imaging the renal masses. I'll be talking mainly on CT. So what should be the approach? Whenever there is a unknown renal mass and the patient's renal functions are normal, first what we have to do is look at it whether it's a cyst or not. If it is a cyst, look for any complexity inside the cyst. If it is that, go for the Bosniak classification that we'll discuss in further slides. Then if it is not a cyst, search for fat, macroscopic fat. If there is a macroscopic fat, that you can see on ultrasound also, better on CT and on MR. If there is a fat, your problem is solved because it's a angiomyolipoma. Whenever there is a no fat, it's not cystic lesion, it's a solid lesion, then you have to rule out few tumor mimics. Those are very easy, though on image it is very difficult to differentiate. But if you look at the history, if you look at the clinical settings, it's not that difficult, because like for example infections, infarctions, or any other known malignancy somewhere else. So these things help us. And whenever it's a primary solid tumor, chances of being renal cell carcinoma are very, very high. So what is the renal CT protocol? Generally what we do whenever, sometimes if it is an incidental lesion, you probably may not be able to do this, but then if it is a known lesion seen on ultrasound, you have to do this renal CT protocol, and that is you have to take a plane, then take a 40-second cortical medullary phase, then take a 90-second, which is nephrographic phase, and then take the excretory phase. All these phases are very, very important, because sometimes there could be dilemma, and if you take all the phases, it will be easy for you to come to the conclusion. Now, what is the role of MR? MR is also equally good, but then the time required for MR and the cost required for MR. So all patients are not subjected for MRI. But whenever there are few indications, like whenever there is a small lesion, what happens is in CT, because if it is a very small lesion, there could be a strict artifact from the enhancing rest of the renal parenchyma, and because of that, even a simple cyst, you will see if you measure the Hounsfield units, on plane it is 9 and on contrast it will be some 12, 13 or something. So this is not the true enhancement, this is pseudo enhancement. So whenever there is a smaller lesion, and this is not a problem with MR, so whenever there is a small lesion, you can think of MR. Then whenever there are, because of calcification, you are not able to make out the enhancement pattern in the lesion, then MR is used. Then whenever there is a contrast allergy to iodinated contrast, you can use MR. And young patients, when there is a chance of repeated imaging, so you can go for MR so that the repeated radiation will be reduced. Now, there are some problems with MR, that is, there is a motion artifact in uncooperative patients. Calcifications will not be seen on MR, and the third important is cost and availability of MR. So these are the reporting elements, which I will not go into the details of that, but these are the things you must give to a urologist before surgery. He needs all these things, that is size, whether it's solid, cystic, fat, everything. So what is importance of this? Like size, whenever the lesion is more than 4 cm, 80% of the solid tumors which are more than 4 cm are going to be malignant. So size is very, very important. Then whether it is solid or cystic, that is also important. Fat, look at the fat. And then enhancement. What I was talking about is, whenever there is a enhancement in the lesion, you have to look at the enhancement, what is the difference in actual, use the Hounsfield units and see how much is the enhancement, because 0 to 10 issue enhancement is not enhancement. If there is increase in Hounsfield units by 10, it is not enhancement, that is because of artifact. So if it is between 10 to 19, it is equivocal. Whenever there is a difference between plane and contrast, if it is more than 20 HU, then only you can call it as an enhancement. So this is very, very important. If there is a 4 or 5 Hounsfield unit increase in the density, it is not, it's a non-enhancing lesion. That is very, very important. And whenever there is a cystic lesion, use the Bosniak classification. Now, this is a simple cyst. You can see on plane, there is. So you can see a lesion here, but plane is never sufficient for focal lesions. So you have to do contrast in every patient, and here you can see there is no enhancement, there is no thickened wall, there is no solid component. So this is a simple cyst. Now I have shown you the Hounsfield units here. You can see there is around 2 Hounsfield units in this plane, and it is about 6 on contrast. So don't call this as a contrast enhancement. This is no contrast enhancement. Now on MR this problem is not there, but whenever you see incidentally, you can see the any mural nodule or septations very well on MR. So again, this is a simple cyst how it is seen on MR. Now here what you can see here, there are multiple cysts. The upper 2 ones are axial T2 weighted images, and the lower ones are contrast. Here you can see there will be no contrast enhancement seen on MR. So the problem of streak artifact is not there in MR. Now this patient, there are multiple cysts here, but out of that you can see here it's a hyperdense cyst. Now hyperdense cyst is a separate entity which comes under Bosniak 2. So whenever it is a hyperdensity, again if it is more than 70 HU on plane, it is going to be benign. So don't worry about that. If it is less than 70, you have to look for the contrast. But whenever there is no significant contrast enhancement and the cyst is hyperdense, it comes under Bosniak 2, that is benign. So this is the classification. We'll not go into the details. These are the findings which are seen. We'll see these findings on the images itself. So here you can see there is a small cyst upper pole of the right kidney. You can see a small bump here on the delayed phase and the nephrographic phase. You can see there is no enhancement. So this is Bosniak type 1, and Bosniak type 1 is generally called as just called as a simple cyst. Now this is Bosniak type 2, you can see 2 or 3 septations and small calcification. Now what about septations? Whenever there are 1 to 3 septations, it is called as less septations. If there are septations are more than 4, it is called as many septations. So less than 3 septations, it comes under Bosniak 2. So again it's a benign cyst of Bosniak category type 2. Now this here what you can see on MR, again you can see these septations better. Here you can see there are multiple septations, definitely more than 3. So this comes under Bosniak type 2F, that is a follow-up is needed in these cases. Now here this is Bosniak type 3, you can see there are nodular enhancing lesions. Now in type 3 and 4, the difference is like if you see multiple enhancing nodules in the wall or along the septi, if these are of obtuse margins, these are considered to be type 3, and in type 4, whenever there is there are multiple obtuse, and if there is a one single enhancement also, but it has a acute margins. So here you can see there is a protruding lesion inside that and which is enhancing. So this comes under Bosniak type 4. Again another example, you can see extensive thickening and thick enhancing septae within. So this also will come under Bosniak type 4. Now what is the significance of this? Like type 1, type 2, malignancy rate is 0, so you have to just ignore it. Type 2F, you need a close surveillance. Type 3, the chances of malignancy are 50, and in type 4, the chances of malignancy are 90%. So accordingly, the treatment has to be done. And the last line I will not read because I am talking in front of urologists, so management I will not talk. This is for the radiologist. So the practical point, what I said is, if it is less than, if it is a hyperdense cyst, no need, no follow-up. You can just say it is a benign lesion. If it is less than 20 Hounsfield units, the enhancement, that is also within 20, it is normal. So you can see sometimes you can see multiple cysts in the kidney which will look like a mass. So this is a polycystic kidney and polycystic liver disease. Now coming to this is all about cyst. So whenever and most of the cysts they will be benign. So most of the cysts will come under Bosniak type 1 or max Bosniak type 2. Whenever the chance to look for chances of malignancy, you have to go for or look for type 3 and type 4. And whenever you are looking at cyst, you have to look at all the corners because if you miss one septi or one enhancing nodule means inside the cyst, you are going to, the grade will be changing. So whenever you see a cyst, look at all the corners of the cyst. Now coming to solid masses, whenever there is a fat within. So whenever there is a fat, it is very, very simple for us, and it is a angiomyolipoma. Another example, sometimes we can see a tiny lesion like this, and if you measure the Hounsfield units, it is a fat. Now there could be huge angiomyolipomas like this. It could be associated with tuberous sclerosis. This patient was having tuberous sclerosis, multiple tumors in the brain, and on ultrasound there was a small angiomyolipoma there. Sometimes you can see huge angiomyolipomas, and there could be a dilemma between like liposarcoma from retroperitoneum and the or angiomyolipoma. In such cases, this cross sign is very important. When you see like this cross sign, it is the lesion is arising from the kidney, so it is angiomyolipoma. So coming to the solid masses, like solid masses, most of the masses, as I said, these are RCC. There are very rare variants, so we will not discuss about that. In cases of RCCs, there are 3-4 types. So the commonest is clear cell, the second common is papillary, third common is chromophobe, and third less common is medullary. And the prognosis is also exactly opposite, like clear cell, the prognosis is very bad, papillary relatively less, chromophobe relatively less. Medullary has very bad prognosis, but fortunately it is very rare, and it is seen only in cases of sickle cell disease. So this is an example of renal cell carcinoma, huge mass showing intense enhancement. So definitely the enhancement is more than 70 to 80 Hounsfield units. So it's a renal cell carcinoma. Clear cell carcinomas will have very vivid enhancement as compared to the other types. So another lesion here, a large lesion here, intense enhancement, and you can see on the excretory phase there is a washout. So there is a washout. The lesion is likely to be more malignant and particularly clear cell carcinoma. Here you can see there are hypervascular mets. These are very common in renal cell carcinomas. So many times this will be seen only on arterial phase. So you have to cover the liver in arterial phase as well. Here another patient of clear cell carcinoma. You can see here there is intense enhancement on nephrographic phase, and on excretory phase there is a washout here. So this is again suggestive of high grade RCC, that is clear cell carcinoma. Another patient, large mass with multiple lung metastasis. Here there is another RCC, but the enhancement is, you can see, less in the kidney itself, as it is less vascular. So that's because of that the liver lesion is also not very hypervascular. So it is showing less enhancement. Here multiple metastases are seen. You can see there is a cystic lesion here and large mass here. The cystic lesion is not enhancing, but this large lesion in the right kidney is enhancing, and you can see huge metastasis in the pancreas. This patient was having metastasis in adrenals also, and there was a huge thrombus in the IVC. So whenever there is a multiple metastasis, chances of lungs are very common, but then liver, pancreas are also very common, and involvement of the renal vein and IVC, that is very, very important. We should mention in our report. Now chromophobe RCCs, again those are very rare, particularly seen in Birt-Hogg-Dubé syndrome, where you can see multiple cysts, particularly in the region of near the pericardium. So in such cases, if there is a associated small, less enhancing lesion in the kidney, it is likely to be chromophobe type of RCC. So it has less malignant potential. Now oncocytomas, coming to benign lesions are very less in kidney. So that's why we say whenever there is a mass lesion seen in the kidney, it has to be taken it as a RCC unless proved otherwise. So this is one example, that is oncocytoma. It doesn't have that typical appearance. It can look like RCC, but then in some cases, like 30 to 40% of cases, you can see the stellate scar, which is exactly like what you see in cases of FNH. The typical appearance of FNH, the central scar with stellate appearance, that is seen in oncocytoma. So if it is seen, it is likely to be oncocytoma. If it is not seen, that doesn't rule out oncocytoma. So it is very sometimes difficult to differentiate oncocytoma from RCCs. Now, here this was a patient came with sudden severe pain. Actually this patient came for spine CT, and because of the severe pain, and the lesion was not in the spine, there was a rupture of a renal mass. So whenever there is a non-traumatic rupture of the mass, it is called as Wunderlich syndrome, but that is used for rupture of the renal mass. But whenever you see non-traumatic hemiperitoneum, the first cause should be taken in mind is ectopic pregnancy, then ovarian cyst, then the renal angiomyolipoma or RCC. Even hepatic adenomas, they have tendency for rupture. So this is a rare case. This patient actually came for some other problem and came for ultrasound. Dr. Priyanka did this ultrasound and she said, I am seeing some lesion in the kidney. Even I saw the ultrasound images, I said, I don't feel that. But she said, I'm very strongly, I feel there is a lesion there. So then we asked for CT. Even on CT, you can see there is not big enhancement, but there is a lesion, bean type of lesion, what we call it as. So it was not exophytic, but then there was a lesion. And then this patient went for nephrectomy, and this turned out to be leiomyosarcoma. So it has a very bad prognosis. But this was an incidentally found lesion. So there were no metastasis. So good for the patient. The nephrectomy was done. Now there are some other lesions, and these are depending on the clinical history. You can differentiate, like this lymphoma. You can see multiple lesions in the kidney, enlargement of the kidney, bilateral lesions, this type of appearance, this type of appearance, or you can see this type of appearance with multiple nodes in the retroperitoneum. This was a known patient of CA bronchus, so that's why we could tell it as a metastasis in the kidney. Then this is the renal abscess. Sometimes if you just this image is seen, you may get confused, but then in cases of renal abscesses, clinically, if you look at the history, it is very easy to differentiate renal abscesses from masses. Now this is in fact typical wedge-shaped periphery situated. So if it is that is seen, that is renal infarct. Sometimes in case of trauma, again, if this image is seen, probably you might feel that there is a lesion here, but look at the history, the patient is coming with trauma. So this is even in a small trauma in the kidney that can look like a mass. This is again another rare entity, renal AVM. The important thing is renal AVMs, they are hypoechoic on ultrasound. So unless you put Doppler, these can be missed. And on CT, this patient was showing this malformation here. So to summarize, whenever there is a cystic lesion, look for the type of the cyst, Bosniak type. Look at the, if it is a solid lesion, look at the fat. If fat is there, is angiomyolipoma. If it is a solid lesion, look at the enhancement pattern and try to count the Hounsfield units of the plane and contrast. And then in malignancies, look at the possibilities. If you can give the possibilities, very difficult, but then you can tell orally the urologist possibility of whether it is a highly malignant or less malignant. You know the types. And if there is some systemic disease, look for that, like tuberous sclerosis or Birt-Hogg-Dubé or sickle cell. In case of sickle cell, if you find a lesion, it is definitely a chromophobe type of renal cell carcinoma. If there is a stellate scar, it is oncocytoma. And in cases of rupture, look for the cause outside the kidney also, and look for the other tumor mimics for which you need clinical settings and history. Then only you can differentiate this.
Thank you, sir. Next, I would call upon Dr. Rajnikant Joshi, sir, for presentation on renal masses.
Arun sir, this is a wonderful conference. We are listening to the both aspects of looking towards same thing. I am here to discuss about imaging in renal masses from a urologist's point of view. What we want as urologists while we deal with these patients. Now, why the need for this talk as a special section in this particular conference? With more regular checkups and our GDP is increasing, people are getting richer, we are having regular screenings, regular checkups leading to higher detection of solitary renal lesions. So now this RCC's incidence is increasing by 3%, almost 3% every year since 1970s. And this is the proven data. Now what do we have with this? We are having panic patients and panic relatives. They went to somewhere with think that ki routine checkup kiya aur usme kuch mila hai. And now there is a mass, they are worried, they counsel somebody else who is not urologist, and they get panicked and they visit us, and they want some kind of diagnosis or further plan on that same ultrasound. And that creates kind of a lot of miscommunication, or I might say inadequate communication. And now we also have a robot in our town. There are already 2 robots in our Sambhajinagar itself. So that creates whether the surgery is required, and all that talk of the town started. So this is the need of hour to communicate about this particular malignancy, this particular set of patients, to have a collaborative efforts between us. So now I am not going to show any images. I'm not going to teach anybody. I'm not a teacher. I am here to put just urologist expectation from all radiologists, what we want from you. So first I'm going to say what guidelines are saying, what we expect on ultrasound, what we expect on a CT, what we should do a MRI or not, or should we do, what should we look into it. And I'm going to talk a little bit about renal mass biopsies. What is required for us intraoperatively, what kind of information we're really looking forward from you to demonstrate this particular patients or operate those patients. And one particular section, as we had a very lengthy and a fruitful discussion about patients with renal dysfunction, I'm going to ask you about few things in imaging with renal dysfunctions. So this is the EAU 2023 guidelines. So it says that contrast enhanced multiphagic CT has a high sensitivity and specificity for characterization and detection of RCC, its invasion, tumor thrombus, and metastasis. MRI has a little slightly higher sensitivity and specificity for small cystic renal masses and tumor thrombi compared to CT. So this one thing I would like to point everybody at, all radiologists, as contrast enhanced ultrasound has a high sensitivity and specificity for characterization of renal masses. This is somewhere we are probably lacking right now. So renal mass biopsies are associated with reduced over-treatment for benign masses and offer patients additional information for an informed decision regarding optimal management. Ultrasound, power Doppler, or PET have a low sensitivity and specificity for detection and characterization of RCC. So now, first and foremost, the first investigation we almost do, every urologist will ask, probably do it himself, is an ultrasound. It's an inexpensive screening modality. What as a urologist we want is that it's okay if we don't get a Bosniak classification right on ultrasound, but we want a definite differentiation between simple and complex cyst. For the sake of purpose, I am saying what simple cyst, what we understand is a smooth cyst wall, round oval shape, without any internal echoes, and thorough transmission with a strong acoustic shadow. And a complex cyst for us is everything else. Even if there is a little thickness of cyst wall, there is some septa, there is any calcification, there is a hyperdense cystic fluid, or any solid nodular component is there. For us, it is a complex cyst, and we are going to image it further by CT before proceeding. For AML, almost all radiologists virtually diagnose those AMLs on ultrasound. So from our point, every mass, which is not a simple cyst, we are probably going to look ahead with a CT. And I'm going to request on this part is that all those patients who are small renal masses are probably frail, and those we are going to keep on follow, kindly save the images. Those images are very important when we follow up the patients. So next is CT. So as sir has already said that we need an enhanced early arterial, parenchymal and delayed phase. For us, our textbook says that more than 15 Hounsfield units of enhancement is significant, and those patients we consider as malignancy. The other information, what we would like from CT is function of a contralateral kidney, the primary tumor extension. Now, while extension, I am going to talk in detail what kind of information we require from intraoperative perspective on a later slide. We need a primary tumor extension, a venous involvement command, a locoregional lymph nodes, adrenal and other organs, and it's not from a guideline point of view, from a person who actually operates a nephron sparing surgery, that is partial nephrectomy, he will definitely request that you need a CT renal angio to have a better vasculature anatomy on the table in hand before proceeding for surgery. And this is one of these three scores. If you do, it would be lot of help for operating surgeon. One of them is which is popular is nephrometric score. So it is based on criteria like radius. The tumor is exophytic, endophytic, its nearness to collecting system or sinus, its location in the kidney, its anterior, posterior, and its location related to polar lines. And the score is roughly divided into three types: it's 4 to 6, 7 to 9, and 10 to 12. Now this score, anybody can roughly judge from plates, but a radiologist sitting at console can give this in the best possible way. And this does make a difference while operating those patients for partial nephrectomy versus a radical nephrectomy or ease of partial nephrectomy. So MRI, I would not hesitate to say that urologists are not very well versed with MRI. We can definitely understand and read CTs, but we are not well versed with MRIs. So we are going to ask you कि किस patient में MRI लगेगा. For us, is the patients with contrast allergies, pregnant patients, those are without renal failures. Now there is some later data is coming into the PubMed is that multiparametric MRI for other than prostate cancers. And there is one interesting study I read yesterday it was characterizing clear cell cancers by likelihood score on a multiparametric MRI by using techniques as DWI and ADC scores. Now, as per guidelines and as per data, it is more sensitive and specific for diagnosing complex cysts type 2F to 4, and it is more sensitive for extent of tumor thrombus in the vein. Now let's talk about renal mass biopsy. Although it is not very commonly practiced as of now in our city, it's the future. So now this is a meta-analysis study which I am quoting in my second point, is that likelihood of benign findings at final pathology is lower at centers which performs renal mass biopsies. So by doing renal mass biopsy in equivocal patients, we are effectively reducing it by 2/3 the patients who are benign patients who are likely to undergo surgeries. So core biopsy of cystic masses is not indicated unless it's type 4. It's not indicated in patients with comorbidities or frail patients who are considered for watchful waiting. This is the rough data from one prospective trial, is that they say if it is a CT1 lesion, at least 2 cores should be taken from solid areas, and CT2 onwards, at least 4 cores should be there. So intraop. So this is the slide I was talking to you about. This is what we require as a surgeon while operating such complex masses. We need its exact location, its relation to our pelvic ileal system. As you might know that partial nephrectomy is one of the most challenging surgeries out there. Many times we clamp the hilum, we clamp segmental arteries and operate the tumor under 30 minutes warm ischemia time, or maybe try to do under lesser time. So we need exact anatomy of arterial tree, venous branches, we need exact endophytic versus exophytic part, and how deep it is from the skin if it is completely endophytic. So this particular image or this 3D diagram is very helpful for somebody who is trying to go ahead with partial nephrectomy. Now this is a very interesting group of patients. We have almost dedicated 45 minutes to talking about patients with renal dysfunction. Those category of patients are also likely to develop this particular malignancy. And in those patients who are on renal functions is borderline, let's say their creatinine is 2 to 3, then nephron sparing surgery, partial nephrectomy is very well indicated. So for us, presently ultrasound is the key of the investigation. That is the one which is going to tell us. Now there is plenty of data which is showing contrast enhanced ultrasound, bubble ultrasounds are promising in those particular subset of patients to differentiate between whether those particular masses are benign or there are more chances of malignancy. Can we have it? Newer nephrologists and newer contrast agent are now saying that okay, we can go ahead, if the risk benefit ratio is okay, we can do a single contrast CT scan. Now that requires further evidence to actually implement into our practice. So I am asking to you as a urologist, to all the radiologists sitting out there, is that contrast enhanced ultrasound, can we have it here? Multiparametric MRI, is it going to really change the way we are going to look at our malignancies of kidney? And if yes, why don't we have it? And this is probably the next big thing, as we have few robots in the town, and maybe future down the line it will become as common as laparoscopy. 3D models along with CT report to have a better judgment and better planning, and let's make that patient's life better by doing imaging better and knowing everything beforehand. So this is all collaboration. Today's conference is all about collaboration. We have exchanged some ideas. Now we are going to share everything. We'll support each other. We'll assist each other. We'll work as a team. Will create a success in eradicating that particular malignancy, and that will inspire a new generation of urologists and radiologists to work better, and will have trust. Thank you.
Now this session will open for discussion and question.
I have to make 3 statements. They are not questions. In our residency days, there was a book called Einard, and the speciality of that book was there were no diagrams or images in that. Still we understood surgery better from that textbook. So Rajnikant's presentation is of that level. No diagrams, but lot of information, useful information packed in that. So I compliment him for that.
Thank you, sir.
2 more statements please allow me to make. I have seen throughout the day lot of CT scans. Please believe me, there are no conditions in urology which need oral contrast. So I don't know why radiologists give oral contrast to patients sent from urology. That interferes with our interpretation, mainly when we want to see something in coronal or sagittal section. It is extremely interfering with our understanding of the disease process. So I am requesting that if you want to give oral contrast to a patient from urologist or for any patient sent from anyone with a urological diagnosis, please confirm from the referring surgeon or physician or gynecologist whether oral contrast was really essential in that patient. Third thing, I am surprised that even today it is happening, is giving IV contrast without at least verbally confirming the serum creatinine report, if not a printed report. In my career, I have seen quite a few patients whom ended up with what not investigations like barium enema, barium meal follow through, and then picking up bilateral extensive staghorn stones, ending up in CKD. A simple serum creatinine by a urologist would have made the diagnosis and would have a simple serum creatinine estimation would have prevented the given injection of IV contrast. So please take my statements in the correct spirit. Thank you very much.
Yeah, I would like to say about the oral contrast. When the patient comes from urologist and indication is clearly written, we never give oral contrast. What happens is sometimes patient is coming from a general surgeon and patient in the history there are few things about the bowel also. In such cases we have to give oral contrast, but many times we ask. I mean, recently 3-4 days back, it was a patient from surgeon. We asked that surgeon, sir, you want to see, I mean, you have any patient has anything related with bowel? He said no. So we didn't give oral contrast. The reason is the problem comes to you also and for us also whenever we are doing coronal reconstructions or the urogram images. Because of the oral contrast, the images are very bad. So even for us, not giving oral contrast, it saves our time also. So we don't give oral contrast generally.
See, even for lower GI malignancy, colonic malignancy, oral contrast may not be necessary. Even a carcinoma rectum, you can do a unenhanced arterial, delayed and venous phase. Yeah. Again, few more things I would like to say about contrast enhanced CT in renal masses or for any urological malignancies. We see films which directly start with arterial phase. Again, I am not casting any aspersions on any of my own radiology friends, but complete information can be gathered only and only if we have plain arterial, delayed arterial, venous and delayed phase. Without this, I don't call a CT, triple phase CT at least a complete CT.
For other conditions also, we do plain studies. I mean, we never do direct contrast study. Probably that person might not have printed, but I think everybody takes a plain because for us, like whenever there is some enhancing lesion is there, whether it is a calcification or something else, so we need to compare the plain and contrast. So generally it is taken.
Initially, when we were doing residency and post-residency, when CT scan was introduced or where it was done for renal masses, the most important thing is to see enhancement. Yes. If it is a complex cyst, say Bosniak 3-4, then enhancement is very important. So what our radiologists used to do is there always used to be a marker on the mass, on plain and contrast, and HU was always mentioned on the film. Yeah, so this practice is now gone. I am not seeing.
We used to do that. We used to mark, or we had stickers also, arrow. But most of the referring doctors, they started mala kalte tel mark takuna ka mark takle.
No, not a mark, not a mark. You just put a marker. There is a round marker or a bullet type of thing which is asterisk on the mass and post contrast image wherever you see maximum enhancement. So on the film only we come to know. Yeah. This is 6, this is 50, or this is 90, or this is minus angiomyolipoma. That is one thing. Secondly, diameter on the film, maximum diameter which is seen on the particular film. I think you should give the width and the length so that on the film at least we come to know what exactly it is. Instead of, obviously we'll see the report, but these two things were given by the radiologist previously, but now everyone has stopped mentioning this.
Not this. It's see the half. No, it's not. Once you open the vial, the content has got a half-life of only 12 minutes. I mean, Within that 12 minutes, either you can. No. I am talking about after giving the contrast. No. You are misunderstanding two things. Number one is you have a vial. That vial, suppose contain X ml, or ideally it is 5 ml. So in that case, once you open that vial, you can do 2-3 patients in that vial. That is no issue with that. But only thing is that if you put a contrast into any object, for that matter, for renal masses, then in those individual, the viability into that individual to identify that contrast or enhancement is never more than 12 minutes. I mean, you need to comment about everything within that 12 minutes. So if I am trained, then probably I will identify all the abnormalities very easily. But the learning curve in identifying the lesion and commenting upon the enhancement and probably is very steep. So learning of contrast ultrasound is very steep, number one. Number two is that the half-life in every individual is never more than 12 minutes. And thirdly, the vial cost is very high unless you group number of people, like on liver, particularly NAFLDs or the cirrhotic livers or those all with suspicion of HCCs. In all those individuals, we can club those patients into 2-3 categories, and we can use 1,6,500 vial for 2-3 patients. But that is not the case in cases of RCCs or other tumors. So that's the reason why it is not gaining popularity in India. So it is gaining popularity in European and the other Western world because they are more or less they are insurance-based imaging investigations where everything is being taken care.
It's not reproducible also. Like if it is not done properly, it is something which is irreproducible. Like you can see the images.
Sir, the only request is this to consider this particularly in subset of patients with renal dysfunction, because for them it becomes very if it is particularly available, probably many of us don't know this is available, as I did know.
100% it is doable in case of renal dysfunction.
MR contrast is almost contraindicated. It causes nephrogenic system fibrosis. Thank you, sir.
Thank you, Dr. Sir and Rajnikant, for wonderful presentation. Thank you so much. Now we'll conclude this session. Thank you.
Next, I would call upon Dr. Sandeep Badhe sir, Dr. Nilesh Kandelwal sir, and Dr. Priyanka Barfe ma'am to moderate the next presentation. I will call Dr. Saurabh Joshi sir onto the dais to present on imaging in carcinoma prostate.
Having a talk on imaging in carcinoma prostate, which probably is a grey zone for both radiologist and urologist.
Sorry to interrupt. I would call upon Dr. Sanjay Surana sir onto the dais for as a chairperson.
So in a previous talk, we just had a brief note about multiparametric MRI in renal masses, which my previous speaker told that has come across recently. I would like to say that the multiparametric MRI for both prostate as well as renal masses has been there since almost 2 decades. And we probably are lenient in using it. So disclaimer, as per Kulkarni sir, none of the images are my own, as we barely get MRI prostate cases in MGM and have been taken from various sources in literature. And no offense to everyone, please. So to introduce, most common prostate CA is most common primary malignant tumor in men, and it's the second most common cause of cancer-related deaths in all men. By far, the adenocarcinoma is the most common histological type, and it is seen in elderly male above the age of 50 years. Clinically, it presents with urinary symptoms like lower urinary tract symptoms such as that seen with the BPH. Patients also can present with the hematuria, back pain, especially those with metastatic disease, an elevated serum PSA level more than 4 nanogram per deciliter, an abnormal digital rectal examination, and a Gleason score of 6 or more. Gleason score of less than 6 is usually considered to be a benign pathology unless proven otherwise. Most commonly, the prostate CA, as we know, they arise in a peripheral zone. About 70% of them arise in a peripheral, whereas 30% predominantly arise in anterior, that is transition zone, without having any component in the peripheral zone. The prostate CA, they usually spread by hematogenous route to predominant bones. That is, we all know that sclerotic and osteoblastic mets are seen. They can also have a local lymphatic spread to the pelvic loads and followed by a distant spread to the para-aortic and inguinal loads. And one specific type of metastasis that is seen with the CA prostate is cannonball metastasis in lung. Some role of transrectal ultrasound, we have been discussing this throughout the day. Role of TRUS in a CA prostate and BPH. In case of prostatic CA, is seen as a hypoechoic lesion on background of a uniformly hyperechoic peripheral and a transition zone. RUS can also be used for guided biopsies, as we have discussed in previous lectures. And another indication for the TRUS is for directing the brachytherapy sets into the prostate glands as a part of treatment. Now coming to the MRI, I will be most of the time limiting my talk to the multiparametric MRI. Primary indication for MRI of the prostate is the early detection, localization and staging cancer before biopsy. That again MR guided prostate biopsy. To look for the extracapsular extension in a biopsy proven cases, to look for the recurrence following the radical prostatectomy in patients with a persistently elevated PSA, and as also for the active surveillance. Now I would like to quote some guidelines here. European Association of Urology guidelines, they say that the staging of the CA prostate should only be tumor node metastasis, but at the same time they mention that if we are staging the prostatic CA on a digital rectal examination and MRI imaging, we should stage it separately, but they say that there is strong correlation between the staging done by the digital rectal examination MRI and as well as the clinical staging. Again, there are guidelines for the first line treatment of various disease stages in MRI prostate, which clearly states that the MRI prostate should be performed before biopsy if there is no MRI done at the time of initial biopsy, and we should take both targeted as well as systematic biopsies in a patient who comes with the PIRATE scores of 3 or more. And this also has got a strong strength rating. Then there are some guidelines for the screening as well as early detection of prostatic CA, which again says that the MRI of the prostate in a patient who presents with a PSA level between 3 to 10 nanogram per ml with a normal digital rectal examination is strongly indicated before going for a biopsy. Then last guideline, last but not the least, there are many guidelines in regarding the CA prostate. This is from the European Association of Radiology. They say that there is a weak association if we do a MRI prostate for local staging, but at the same time when we do a MRI prostate for guiding the biopsy, at the same sitting we can stage the disease. Current daily practice, there is a tendency to perform multiparametric MRI before obtaining a biopsy. Now what is multiparametric MRI? It is the multiple in this case, in multiparametric MRI, what we do is we assess multiple parameters of prostate signal intensity as per the guidelines given in ACR, PIRATES and European Society of Urogenital Radiology. That is, we look at the T1, T2 signal intensity, DWI and ADC values, dynamic contrast enhancement, and it is an accurate tool in detection of clinically significant prostate cancers. MR spectroscopy does not form a part of multiparametric MRI. A brief about the MR anatomy of the prostate. We can see starting from the base, we can see here there is a seminal vesicle which appear normally hyperintense on T2 weighted images. This is the mid portion. This is in a normal patient, and this is a patient with the BPH. In a normal patient, the central and the peripheral, central and transition zone look like an intermediate and a hypointense signal intensity, whereas the peripheral zone has got a uniform hyperintense signal. Just a second, I'll take a pointer. Yeah. So this is the peripheral zone which looks uniformly hyperintense on T2 weighted images. This is a patient with the benign prostatic hyperplasia, where we can see that the transition zone is enlarged and shows intermediate signal intensity. And because it is enlarged, we can see a pseudocapsule formed by a compressed peripheral zone. And these are the areas where we see the neurovascular bundle. That's the rectoprostatic angle. these two have a bearing on determining whether there is an extra prostatic extension of a CA prostate. Another patient here, we can see there is a hypertrophy of the transition zone, which has significantly compressed the peripheral zone, and that's the apex of the prostate where we see the periurethral area or the prostatic urethra. Coming to PIRATS, PIRATS classification was introduced in 2012 for standardization of acquisition, interpretation and reporting of prostate MRI. The PIRATS assessment categories are based on the findings of multiparametric MRI. In PIRATS version 2.1, clinically significant cancer is defined on pathology as a Gleason score of 7 or more, including 3+4, with a prominent but not predominant Gleason 4 component, tumor volume more than 0.5 cc, and extra prostatic extension. We will first discuss about the peripheral zone, and followed by that we will discuss about the transition zone on PIRATS. For peripheral zone on a multiparametric MRI, DWI and ADC are the primary determining sequences, whereas the dynamic contrast enhancement is considered necessary when PIRATS score 3 or 4 are seen. As compared to PIRATS 2, in PIRATS 2.1, there was a more precise description of a peripheral zone lesions in category 2 and 3, and there were two more sectors were added in peripheral zone, as I told in the morning lecture, peripheral medial zones in the medial sections for the peripheral zone. Coming to peripheral zone, category 1, which is a normal patient, where we see a normal transition zone of intermediate signal intensity and a peripheral zone of a peripheral signal, T2 hyperintense signal intensity. No abnormal signal is seen on the ADC, and there is no hyperintensity on DWI. Category 2 lesions, where we can have a wedge-shaped signal on a ADC, but there is no discrete focal lesion. Which is this wedge-shaped lesion is seen as an hyperintense lesion on a DWI and an hyperintensity or a hypointensity in a peripheral zone on T2. These patients usually come with the benign prostatic hyperplasia. PIRATS category 3, here we now start seeing the focal hypointensity on ADC, which appears as a hyperintense on DWI. In this case, we look for the dynamic contrast enhancement. If there is a focal early enhancement, we reclassify this category 3 lesion as a category 4, and if there is no enhancement, we stick to the category 3. So this is a focal lesion in a focal hypointensity here in the peripheral zone on an ADC, which is seen as an hyperintense lesion on DWI, and it's a very smudgy appearance on a peripheral zone. This is one example of PIRATS type 3 lesion. You can see a diffuse hyperintense signal on a DWI, hypointensity in a peripheral zone, and a smudgy appearance in a peripheral zone. So in this case, we must go ahead with the dynamic contrast enhancement to look if there is an enhancement or not. If there is an early enhancement, we categorize as a category 4, which has got a higher risk of malignancy than the PIRATS 3 lesions. PIRATS category 4, here again more discrete and homogeneous nodules are seen on an ADC and DWI, and these are now seen as a hypointense lesions on T2 weighted images. So this is one case where we see both PIRATS 3 as well as PIRATS 4 lesions. As the Mahajan sir was telling, that we need to take multiple biopsies. This is the reason why we take multiple biopsies, because we tend to find lesions with multiple PIRATS categories in a single prostate. So here we have a PIRATS category 4 lesion, which is looking like a focal hypointense lesion on a left side, whereas on a right side we see a very smudgy hypointensity on ADC. So this is again a PIRATS 4 lesion. There is a focal hypointensity seen in DWI, focal hyperintensity on a DWI, hypointensity on a ADC, and hypointense lesion on T2. Lastly but not least, most important category, which is category 5, which has got a highest risk of being a malignancy. It is same as that of the PIRATS 4, but when size is more than 1.5, we classify it as a PIRATS 5. Coming to the few examples of PIRATS 5 lesions, we see here a large ADC hypointense lesion, which is hyperintense on DWI and is seen as a hypointensity on T2 weighted images and is more than 1.5 centimeters. So we label it as a PIRATS 5 lesion. Another example of PIRATS 5 with extra prostatic extension. This is the pseudocapsule of the prostate formed by the peripheral zone. Here we can see that there is a irregularity of the prostate capsule in the region of neurovascular bundle, so indicating that there is a possibility of involvement of neurovascular bundle. This gives us an idea that this has a locally advanced prostatic CA, and that helps us to stratify our treatment guidelines. Coming to transition zone, transition again is classified into 1 to 5. Here again transition zone, like in a peripheral zone, this is a normal prostatic CA or a patient with a prostatic hyperplasia, where we see a intermediate signal intensity on a transition zone and no abnormality on DW and ADC. For transition zone, T2 weighted images are the determining sequences, and if we find some abnormality like a PIRADS 3, we use DW and ADC values to reclassify it as a PIRADS 4 or 5. Transition zone 2, here these are the examples of BPH. We see an encapsulated or an atypical nodule or a linear hypointensity. Category 3 lesions, again these are heterogeneous signal intensity on T2 weighted images with obscured margins. Here, just like we did for the peripheral zone, if in this case the DWI has a score of less than 4, we keep it as a PIRADS 3, but on a DWI, if the score comes to be 5, then we reclassify it as a PIRADS 4, because the PIRADS 4 lesions again has a higher risk of malignancy. So this is an example of PIRADS 3 lesion. You can see an hypointense lesion on a T2 in a transition zone at the level of border between the transition and peripheral zone, which is seen as an hypointense on ADC and an hyperintense on DWI. Category 4 lesions are lenticular or non-circumscribed lesions, homogeneous, they are moderately hypointense but less than 1.5, and category 5 are same lesions with a size more than 1.5 centimeter. So this is a lesion which involves the transition zone and is extending near the anterior fibromuscular stroma, is seen as a low signal intensity on ADC and shows high B, hyperintense signal on high B values. And one more thing I just forgot to mention, that when we do an multiparametric prostate MRI, we should always do a DWI sequence with a high B values, that is more than 1000. This is another example. This involves the transition zone and the anterior fibromuscular stroma. Same patient. Cat 5, as I explained, is the same as that of the category 4, except that the size of the lesion is more than 1.5, and or there may be a definite extraprostatic extension or invasive behavior. For example, here there is a lesion in the transition zone which is also extending to the peripheral and also causing a bulge in the prostatic capsule. So there is a definite extraprostatic extension. A few examples here. This also is a lesion in a transition zone. We see some lesions in transition zone, these two nodules, but these are encapsulated and of intermediate signal intensity. So these constitute the nodules of the benign prostatic hyperplasia, whereas this lesion does not have a well-defined margin. It shows an restriction on DWI and is low signal intensity on ADC. So we classify it as PIRADS 5 because the size of the lesion is more than 1.5. Signs of extraprostatic extension include seminal vesicle invasion, neurovascular asymmetry, frank capsular breach, obliteration of rectoprostatic angle or a capsular bulge, and a broad contact with the capsule. Like this here, we can see both there is a breach in the capsule, there is a bulge in the capsule, and normal T2 hyperintense seminal vesicle shows a loss of T2 signal and is appearing diffusely hypointense. So this constitutes clinical stage 3. Some examples of locally advanced carcinoma of prostate. This is important to note before going for a biopsy as well as for the treatment, the extent of the lesion, since involvement of a rectum or levator ani precludes the surgery, and we can go for treatments like androgen deprivation therapy or prostatectomy. Dynamic contrast enhancement is usually in a patient with a CA prostate shows early contrast enhancement as compared to the background parenchyma. Here we can see this is a case where we see an lesion in the peripheral as well as transition zone. On dynamic contrast enhancement, this lesion shows an early enhancement compared to the rest of the normal parenchyma. Again, AAU has also stated that MRI is useful in active surveillance of the patients for the patients who have a PSA rising after the treatment. Some examples of the recurrence following surgery. This is a patient where see a T2 hypointense lesion at the level of vesico-ureteric junction, and it is extending to involve the base of the bladder as well as the anterior wall of the rectum. MRI is also useful to look for the metastatic burden, particularly the spine, especially those patients where a CT scan may not depict the metastasis as good as the MRI, since on MRI, a metastatic lesion would look like a hypointense on T1, that is loss of normal T1 fatty marrow. Similarly, it will appear hyperintense on STOR sequences. There are some pitfalls in the diagnosis of carcinoma of prostate on MRI, that is prostatitis, but prostatitis usually has an intermediate signal intensity on T2, not the low signal intensity, and does not show much of diffusion restriction on DWI and appears very intermediate signal intensity on ADC and not the markedly hypointense signal which we see on a prostatic CA. Benign prostatic hyperplasia and another pitfall in diagnosis of CA prostate, especially in the transition zone. Here we see it's a well-defined nodule which is very unlikely to be an CA prostate. There are multiple nodules which show a capsule, which also show a nodule within nodule appearance. These are all signs of benign prostatic hyperplasia and not the CA prostate. There are screening guidelines, so at every stage the European Association of Urology has stated guidelines for the MRI, and they mention that the MRI can be used both for the early diagnosis, detection, staging, screening and active surveillance, as well as for the guidance of prostate biopsy. Screening guidelines of EU says that the inclusion of MRI may improve a screening protocol as it reduces the number of men that undergo biopsies while detecting more high grade and less low grade prostatic cancer. I think this is very important because the morbidity associated with the prostatic biopsies, though they say that the weak strength reading for the when we do a MRI for staging purpose. MR spectroscopy, as I stated, has not been included in a multi-parametric MRI. Normal MRI has got normal citrate level, whereas in a prostatic CA, what we see is a increased choline levels. CT has got a limited role in evaluation of prostatic CA, specifically useful for detection of osteoplastic mets or mets to the lung and for guiding radiation therapy. That's all from this side. Thank you all.
Thank you, sir. Moving to the last presentation, I would call upon Dr. Mayur Dalvi, sir, for presentation on CA prostate.
Thank you for the opportunity. I would like to continue the topic from urologist's point of view. So, how do a urologist approach when he suspects a CA prostate? So, initially a positive digital rectal examination with a raised PSA. If these two findings are there, we directly go for a systematic truss guided biopsy. When it is positive, we consider doing a local staging and metastatic staging. So looking at modalities that we have for imaging, first USG, rather adding this point was because I just went through a sonography, abdomen pelvis stating that there is cancer prostate. So USG abdomen pelvis where prostate is mentioned is not beneficial as a primary modality. Second thing is multi-parametric MRI. Third is CCT abdomen and pelvis, and upcoming is multi-parametric sonography. So as said, initially it is for primary diagnosis and second is for staging workup. So indication for imaging. So as in the first slide, if the PSA is more than, repeated PSA is more than 10 with a positive DRE, we directly go for biopsy. The first indication comes when it is in the gray zone, that is serum PSA is between 4 to 10. The second is when with a raised PSA there are negative biopsies. The third is a person with a family history of cancer prostate and who needs regular follow-up. Rather biopsy is cumbersome and even may lead to serious complications. Fourth is after some intervention, say after radical prostatectomy, after focal therapies or after radiations. So what do we expect? So multi-parametric MRI should be considered prior to biopsy as told by Joshi sir. Sensitivity and specificity depends on especially the expertise of at the center. Second is quality of imaging equipments, and third is grade of disease. That is, it is more sensitive, more than 90, and specific more than 80 when the Gleason score is 7 or more, that is ISUP grade 2. So what is your expectation from urologist? As we all know, when it comes to MRI, we don't dare to even remove the films from the pocket. We just read the report and that's it. So accurate PIRAT score. So if the score is positive, that is more than 3, combined targeted and systemic biopsy approach should be considered to get the best biopsy results. Third, what we would like to know is local invasion in form of rectal proximity, seminal vesicle involvement, lateral and neurovascular involvement that may help us during the radical prostatectomy. And third point is enlarged lymph nodes. So usually most of the reports say that the lymph nodes are enlarged. Rather, we consider it as metastatic or positive lymph nodes in pelvis when it is more than 8 mm and more than 10 mm when it is extrapelvic. So if this information is added, we can go with a more radical approach to the specific sites of lymph nodes. That's it. Thank you.
Any questions?
Saurabh, what is your experience about PMSS scan over multiparametric MRI?
Sir, they state that a PMSS scan is useful for diagnosis of metastasis, but when we say for local staging and extra prostatic extension, which is very useful as far as the urologist is concerned, whether to go for a radical prostatectomy or radiation therapy or androgen deprivation therapy, I think multiparametric MRI stands alone over the PMSS scan. And as sir has also told, we should, any patient suspected of prostate CA whose PSA is elevated more than 4 should always go for an MRI prostate before going ahead with any treatment or a biopsy. And one more thing I wanted to say, sir said that the reporting and the interpretation of the MRI prostate depends on the expertise. I would like to say the expertise developed when you see the patients. So if our physician are not sending the patients, then there is no development of expertise. Of course, sir. We cannot call patients and ask them to get the MRI prostate.
If there are no questions, we conclude the session.
Thank you, chairpersons. And next, I would like to request Dr. Iqbal sir and Ms. Kotkar sir to give a vote of thanks.
I call Dr. Arun and Dr. Ajay Oswal. Please.
बोलने वाला तो एक ही चाहता है आप सिर्फ खड़े रहेंगे प्लीज सर
Pardon. Dear friends, since morning we had very fantastic lectures, presentations, and very great discussions. Exactly, we came to know what a urologist expects from us and what we need to change in our reporting system. I think, Ajay, what I feel is we should form a format.
Yeah.
A format should be formed so that we can make the reporting system as such.
SOP.
Standard. Yeah. So that's better, I think. First of all, I would like to thank Aurangabad Urology Association because Anirudh, especially Anirudh had a thought. Ajay and Anirudh, and of course Arun, and of course Sonali and me and Prasanna, we were in loop, and they have taken maximum possible efforts to make this symposium a very grand success. I think in the future also we'll have such discussions going on. I would like to thank Mindray, all the sponsors, and first of all the delegates. Since 9 o'clock from the morning, they're till 4 o'clock they are here, and they have not wasted their Sunday. That is most important thing. आखिरी एक बात एक शेर से ख़त्म करना चाहूँगा कि क्योंकि एक बात ये भी बोलना है कि इसके बाद हाई टी है हाई टी आपको सबको लेके जाना है, तो उसी तरह मैं अभी बैठे बैठे एक शेर लिखा मैंने और कहा कि ज़िंदगी, हाँ, थैंक्स टू MGM ऑल्सो, MGM का स्टाफ, कोलगे एंड ऑल हिज कलीग्स, thanks to Department of Radiology, Department of Urology, Mindre, I already said, Mindre, then Department of Radiology and Urology, all the residents of radio department, and Khalid Bhai and his entire team for AV. तो सब लोग हाई टी लेके जाइए. एक शेर से इसका ख़त्म करता हूँ कि ऐ ज़िंदगी आ बैठ चाय पीते हैं. अब हमको चाय पीने जाना है इसलिए ऐ ज़िंदगी आ बैठ चल चाय पीते हैं. तू भी थक गई होगी मुझको भगाते भगाते.
सर लेकिन अभी चाय का टाइम, अभी टाइम और थोड़ा लेट होते तो
मैंने हाई टाइम रखा है ना उसके बाद का मुझे बहुत